We are quickly going to talk about, while we're just preparing in the room, we are quickly going to talk about snare placement technique as it relates to the differences between hot and cold. You may not see any hot snare polypectomy today, and that's a function of the fact that actually in most people's everyday practice, you should not be doing hot snare polypectomy. It's not necessary, and it's usually dangerous to the patient because the majority of polyps that we find are small, under 10 millimeters in size, and suitable for cold snare. So potentially, once we get screen sharing, we can discuss the pros and cons of that and how that fits into the differences between different types of snare and different technique. So the objectives are talk about choice of technique, and then I've got another presentation on that. And if you want to know at that, as in why do hot, why do cold, go have a look on GIEQs Online. We had a session on it in the last symposium. We'll have a session on it in this year's one, and there's also some lectures on there about that. Snare selection, which snare should you choose? The 4 Ps you've already had mentioned, but let's go into them as versus hot and cold, and then look at the ESG guideline quickly. So you have got multiple snares available to you as a endoscopist, but just to give you a general idea, we recommend using maximum 20 millimeter snares, and only in the left colon 20, 15 everywhere else. And actually my practice is the majority of the time I'm not working the rectum, which I'm usually not because I'm not doing much EMR in the rectum at the moment. Use a 15 millimeter snare for everything. If you are talking about hot, then some good snares are either the Captivator 2 from Boston or the Snare Master from Olympus. You can see them there and the differences between them, but the big difference between hot and cold snares is the wire diameter. So hot snares are normally bigger than 0.4 millimeters in diameter, the wire, and cold under 0.4. And then you have some cold snares here listed, and you can take your pick of those. So that this would be a chart that you could store and decide to decide where you want to start with your snares. Snare placement technique, and we'll go through it in a minute, but the general thing is, well, think if you're going to do a hot or cold, choose the right snare. Think about folds, think about downhill, think about using injection to promote the lesion into the place where you want to be. And be very considerate about difficult locations. They're listed there. So flexures, appendix, ileocecal valve, and anal verge in terms of the snare that you choose. And actually, if you look at our more advanced courses, this is not going to go into that in these. Then there's lots of information, lots of videos, lots of discussion about what to do in those situations. Make sure that the lesion's at 6 o'clock. Make sure the gravity is in your favor, as in it's not all over the thing you're trying to resect. And think about the type of snare. In terms of plane, well, think about muscle folds and think about being uphill and using injection to get uphill if you're already think that you're in a downhill position, and keep close to the scope. So these are really universal principles for snare placement. And we talked about a lot of them, but one of them is this pivot technique where you embed the tip of the snare in tissue and then you move the snare around. And so if this is maybe actually 6 o'clock, then you can transform to we transform 90 degrees and then 100 degrees around to 12 o'clock, etc., etc. So you can use this technique in difficult situations. Actually, I use it a lot in my practice, but it's something that you maybe don't need to start with. So let's compare snare placement technique for hot and cold. I went into this in the last case of it with Elizabeth, but she did a very nice hot snare placement technique at the start of that video. And so, well, what do? You kind of want to promote tissue to come into the snare and the maximum amount of tissue possible. Whereas with a cold snare, you can push out and really embed the snare wire on the wall to get the tissue to capture. But however you do it, you need to exert firm downward pressure on the essentially on the tip of the catheter, and therefore you have to have the snare in the right position out, and that is not like this. Okay, so this is way too far out because all the pressure is going to go here, and this is bendy. So you want absolutely for it to be like this, where the catheter tip is just letting a V of snare wire out. And we talk about the V of a snare, and that's really this part. Okay, so we can illustrate that a bit here. So this is good, I guess. You have a nice bit of normal at the front. Some would say too much. I don't agree. I think there's not ever too much normal that you can take at the front, as long as it's got some polyp on it. You've got a nice piece of tissue in the snare, right? So that's very important, that you have tissue, like the tennis ball of tissue in the snare, that it's three-dimensional, that you can see it, right? This is the opposite. This is not going to work. The snare is going to come in here and pivot off this piece of tissue. And it is in this situation very difficult to backhand this point of the snare far enough back, because it would have to be here to get this tissue to capture. So try not to do this. And the difference between this and that is that this is at 6 o'clock. There's loads of tissue in the snare, and there's not here. And it's not at 6 o'clock. The other important thing about this is that this is the defect line. And so it would be much better that a long axis of this snare was in this line. And you might say, well, you can't do that. Like this picture shows you can't, but actually with suction and repositioning, and it, therefore most about scope positioning, you definitely can do that. Snare closure, how do you do it? Well, you do it with gold snare. You just close the snare to resistance, ensure the placement. You don't need to do a mobility check. We said this in the last case, and you can just ask the nurse to cut through it. If it doesn't cut through within 5 seconds, then you can use the guillotine technique, which is pulling on the tip of the colonoscope with the catheter. Search that on GIEQs Online if you want more details. Hot snare is more about ensuring that the snare is quite closed for the effect of, okay, we're ready, I think. Thank you for showing. For the effect that we had in the presentation you saw on electric cautery, where if you have got the more you've got your snare closed, the better you're going to get cutting through. Also, we want to get the muscle out of the snare, so that does happen the more you squeeze, and we want to make sure that the mobility is good. All of this is about ensuring the muscle is not in the snare. With cold snare, you're going to have to try extremely hard to cut the muscularis propria. With hot snare, you don't have to try hard at all, and it will just cut with the electrosurgery. So those are the differences, and you see it here, closing the snare to a short amount. Checking mobility, etc. Okay, so that's a little bit about the differences between hot and cold, and we will now jump. Well, I won't jump, but I'll walk to the procedure room, and we'll join our lovely Italian friend who has just got the scope. Hopefully, has he got the scope in the cecum himself?
Yes.
Wow, there we are. Well done, Michele. Right, I'm coming to.